Hi, everybody. I'm Chris Raeburn. I'm an endocrine surgeon at the University of Colorado, and it's a pleasure to be hosting this event on hyperparathyroidism. I'll be one of the co-moderators with Benzon, and we have an excellent panel of experts to help get us through this and answer some of your questions about hyperparathyroidism. I'd like to have the panelists introduce themselves now.
So I'm Benzon. I'm co-moderating with Chris Raeburn from Mayo Clinic.
Hi, my name is Insoo. I'm an endocrine surgeon at the University of California, San Francisco, and I'm really happy to be here.
I'm Dr. Scott Wilhlem. So I'm an endocrine surgeon. I'm at University Hospitals affiliated with Case Western Reserve University in Cleveland, Ohio.
Hi, my name is Geeta. I'm an endocrine surgeon at the University of Iowa Hospitals and Clinics, and I'm also the chair of the IT committee for the AAES. I'm very glad to be here.
Hi, I'm Melissa Sum. I'm an endocrinologist at New York University Langone Health, and I'm thrilled to be here.
Okay, great. I also wanted to mention that we're co-hosting this event with the Parathyroid Disease Support Awareness Group. They'll be participating as well. So I thought maybe we'd start off just by saying, how do you make the diagnosis of primary hyperparathyroidism? How do you know you have it? Geeta, do you want to start us off?
Sure. Just before we kind of dive into the questions, I just wanted to do some IT housekeeping things, if that's okay. Just a reminder to everyone that, today's Facebook Live webinar will be available on our YouTube channels, the AAES YouTube channel. In case you miss it today, you can still catch up with it there. And as well, just a reminder again that people can enter their questions on our Facebook feed right now. The moderators will be taking a look at them and asking the panelists your questions as well as others. So back to the diagnosis part. That's a great question. Usually by the time I've seen a patient, the diagnosis has been made. But in the rare instance where it hasn't, where someone's been found to have a high calcium, the next steps are usually to get some additional lab work, which would include a parathyroid hormone level, some electrolytes, including creatinine, to look at the kidney function, as well as a vitamin D level. That's what I would sort of start off with. I don't know if others want to chime in on what they would do to make the diagnosis.
That's a common referral question that I do get in my endocrine clinic. And typically what happens is, like Geeta was saying, I'll get referrals. We'll get referrals as endocrinologists for people who come in and they're found to have a high calcium level. And then the first step to figure out the next part of why someone has a high calcium level is to check that parathyroid hormone. And then if it's high or if it's inappropriately normal, then we would be strongly suspecting the possibility of primary hyperparathyroidism, which is the most common cause of hypercalcemia and typically affects 1 to 3 out of 1,000 people, mostly middle-aged women. And then from there, we'll do the additional labs like the creatinine, the vitamin D, oftentimes the ionized calcium, and then also a 24-hour urine collection looking at the calcium level, because it helps us really cinch the diagnosis of primary hyperparathyroidism. Sometimes there's a very uncommon entity called familial hypocalciuric hypercalcemia that can also have a high calcium and a high parathyroid hormone level, but it's not very common, and that 24-hour urine can help us look at those two. These days, like Geeta was mentioning, a lot of times it's based on blood work that we pick up on the diagnosis. Prior to the 1970s, patients often were diagnosed but when they had a lot of symptoms like kidney stones or fractures or other things. But then in the 1970s, calcium got added to the basic metabolic panel. So these days, really, the majority of patients, at least 80%, are asymptomatic, and we find it based on blood work.
So the rare familial cause that you mentioned is one of the things to exclude. Any other things? I know that occasionally patients ask, whether or not it could be due to cancer.
That's a great question, Chris. So When that high calcium level comes back, yes, the doctors will have a pretty big differential. And then typically, if it's being caused by a cancer, it's going to be a low PTH state. So hypercalcemia of malignancy comes along with a low PTH state, not the high or the normal one that we typically see with primary hyperpara. Very, very, very uncommonly, there could be parathyroid carcinoma, but that's extremely rare. The majority of the cases in which we're seeing high calcium with a high or inappropriately normal PTH will be from primary hyperparathyroidism, which is typically a benign disease.
Absolutely.
I think you also mentioned that you could potentially have a high normal parathyroid hormone level, but still have hyperparathyroidism. How does that work?
That's a good question too. So the parathyroids, we have pretty much typically 4 parathyroids. They're located in the back part of the thyroid, and their job is to keep the calcium level normal. So the body's really, really smart. Its main job is to maintain homeostasis. So under normal conditions, when the calcium level is high, it acts on a receptor called the calcium sensing receptor in the parathyroids, and then the parathyroids know it, and they really stop the release of parathyroid hormone. So it becomes low. That's the normal response. For it to be normal is showing us that the parathyroid has a little bit of autonomous function because it's not being low, it's not being suppressed. And that's a sign that it can be overactive.
Great. And I think there's also an entity called normocalcemic hyperparathyroidism. How does that affect your decision of whether or not a patient has hyperparathyroidism or might need surgery? How about Scott? Let's get you into some of this.
Sure. So, I think normocalcemic hyperparathyroidism is a little bit of a difficult diagnosis. I think, it's one of the things that we do see. And the first thing you have to do is exclude that it's not from another potential source. So we can have patients that come in, they may have some symptoms. They may have some fatigue. They may have some bone issues. These may happen in postmenopausal women who do have some baseline osteopenia or osteoporosis on their DEXA bone density test. So they meet some things that might look like hyperparathyroidism. They didn't feel well, so they got some laboratory testing done, and someone at least was thinking about the diagnosis. So they ordered a calcium that was normal, and then they also ordered a parathyroid hormone level that could be, again, high, or it could be inappropriately normal. But again, that becomes more difficult when the calcium itself is not elevated. So in that situation, I guess a couple of things that really have to happen is, number one, I would certainly start out by sending repeat laboratory testing in that patient if they came to see me. And I'd start out with another calcium level. And along with that, I would get a renal function panel. We want to start looking for other things that might raise the parathyroid hormone level, but not be primary hyperparathyroidism as their diagnosis. So we want to make sure that they don't have elevated creatinine or poor renal function that may start to cause their parathyroid hormone levels to elevate. We also want to check to make sure they don't have low vitamin D levels, which is a form of secondary hyperparathyroidism. The parathyroid glands respond very much so to low vitamin D. Certainly where I'm at in Cleveland, we most of the year see a very high percentage of our patients with low vitamin D levels. So there's been some really nice research done. And if you draw a line across the United States at the 37th parallel, that's the line above that you are at a much higher risk for vitamin D deficiency, especially in the wintertime. And so we'd want to check that to make sure that's not a source of hyperparathyroidism for that patient. And then I think the next steps are some of the things that Melissa brought up. Getting the 24-hour urine calcium level can be extremely helpful in those patients. And if you've really narrowed it down at that point and you feel that the patient does indeed have high PTH levels, that you've excluded other sources, and also the ionized calcium Melissa mentioned is very important too. We want to see that that level also technically should be normal in that diagnosis as well. We want to make sure that we've excluded things. Then you could start at least thinking about working your way down imaging and other things that might lead you toward a potential surgical intervention. But it can be a much more challenging diagnosis to make.
If I can maybe add on, oh, sorry.
No, go ahead, Insoo.
If I can add on to that just a little bit, I think from the patient perspective, a lot of folks with a presumed or suspected diagnosis of normocalcemic hyperparathyroidism are very frustrated because, you know, there's some patients with primary hyperparathyroidism where you only need like maybe a few set of labs, maybe even one that has really definitively diagnosed you, right? Someone comes in with a calcium of 12 and a PTH of, you know, 150, 200, you know, and you pretty much know that you have a primary hyperpara. Normocalcemic, because of what Melissa and Scott were saying, requires a lot of thought and care to make sure that you have the right diagnosis. Because, you know, it'd be very poor form if we wound up taking this patient all the way to the OR and did an operation that was not therapeutic because we had the wrong diagnosis. So, you know, having a really detailed level of discussion with the patients is important so that they understand. Sorry, somehow I got muted.
Just at the very end there. So I think we got the gist there. It's got to be really careful before you confirm that somebody has normocalcemic hyperparathyroidism. And Melissa, you had mentioned that a lot of patients, you know, back 30, 40 years ago, that almost all patients presented with symptoms, but nowadays, you know, we sometimes diagnose people before symptoms. But what are the symptoms or problems that hyperparathyroidism can cause people?
That is a great question. And I also just wanted to add that for these diagnoses, we will also always ask patients about whether they're on any medications that can be associated with high calcium and or high PTH, which would include lithium and thiazides. So blood pressure, pretty common blood pressure medications like hydrochlorothiazide or chlorthalidone. So those would be screening questions too, because they can also contribute to those labs. And then you were asking, what are the symptoms of hypercalcemia? So this always stood out to me ever since medical school, because how I learned it was the bones, stones, groans, and psychic moans. Those can be features of really, really severe hypercalcemia. The stones features are kidney stones. So the high calcium can lead to calcium kidney stones. And then the bones can be from bone fractures, because where's the calcium coming from? It's coming from the bones, and that can lead to osteopenia, osteoporosis. And then the groans can be from constipation, from significantly high calcium or nausea, vomiting, abdominal pain. And there can also be altered mental status if the calcium is really, really, really high. That's for severe hypercalcemia, but these days most people it's not that severe. So a lot of the different symptoms that we may see can be a little bit less than that. We can see and pick up on osteopenia, osteoporosis before someone has fractures. We can find kidney stones before they become asymptomatic. Patients often do tell us that they're tired, they're fatigued, they feel like there's some brain fog or some difficulty concentrating, some difficulty with memory, some changes in their mood. So there can be a lot of some of the less specific symptoms as well.
So,
hey, Chris, I'm just looking, I see that there's a question that came in from Facebook, I think that kind of goes along with the diagnosis, and someone asked, when a patient with high suspicion, prior blood work consults with a non-surgeon endocrinologist in advance of preparation, what are the most important items to bring to the appointment? So just, you know, for me, when we have patients that call and are being referred, or if they call and are asking for a direct consultation with me for hyperparathyroidism, we ask them to gather up any blood work that they have had done, hopefully within the last year. If they have things that predate that show a trend of calcium for a long time, very helpful. If they've had any records, if they've had any imaging done, if someone already started a workup and a diagnosis, if they can let us know where the imaging was done at, so that we can go ahead and try to request those images to be sent into our radiology system so I can review them before the patient comes or at their appointment with them. And lastly, if it's a patient that has already had surgery, which is a whole nother line of questioning, but extremely important to have prior operative notes and prior operative pathology reports. So those are the things that I find extremely helpful if patients can gather together before they come see me.
sure. And, you know, we try and have in our clinic, our secretaries kind of gathering all those things. As a patient, if you just kind of keep a record of all those things, it makes everything a lot easier, so that you're sure you're not relying on a secretary or some other hospital to send those things, because sometimes it doesn't happen as quickly as you'd like. So,
Oh, sorry. And to add to what Scott and Chris said, if you don't quite know when the hypercalcemia first started, it's helpful to check in with your parents too and ask, well, did I have a high calcium when I was a kid or when I was a teenager? And also to check in on the family history. Ask your parents, ask the family, have they had high calcium, hyperparathyroids, kidney stones, other potential endocrine associated disorders?
It's amazing how much you find out once you go back and ask those questions. And I just wanted to add one more thing to something that Scott said, which is that medication list is important, not only for those diuretics that, you know, can cause a high calcium or lithium, but a lot of patients are sometimes on things like loop diuretics, right? They're on Lasix that can actually artificially sometimes lower their calcium. So you can see some low calciums and some high calciums. And it's, again, all of those pieces of information are important. And if you go to the AAES patient website, you know, there's actually a list of things that, you know, you can look at in terms of questions to ask, you know, at your appointment with the endocrinologist or the surgeon, and what are the sorts of things that we'll be looking for. So that's kind of a helpful place. I just wanted to point people there in case they weren't familiar with that site.
And
You know, this is something that, sorry, go ahead, Benzon.
Oh, no, I was just going to go on to a next question, but Insoo, why don't you go ahead?
Oh, I was just going to say, as since this is all relevant to the IT committee and technology in general, I did want to put in a slight plug for why technology is great in medicine. Now that a lot of our systems are electronic medical record, you know, dependent, I guess, and have a lot of crosstalk. You know, we have Epic, and, you know, I'm sure other people have different systems, but it's actually much easier now to go back to historical calcium levels. Even in patients who may not have remembered that they had gotten a lab done back in 1994. And in those, you know, situations, I found that the diagnosis for some of the more subtle cases have been maybe a little bit more straightforward. If we find someone that had a normal calcium back in the day and then developed hypercalcemia, I don't necessarily need to get a 24-hour urine in some cases. You know, in many other cases, I will still get it, particularly to see if they meet indications for surgery, which I guess we can talk about a little bit later. But, you know, just a plug for technology being great.
Great point. Care everywhere is very helpful.
Yeah.
We may have lost Benzon, but I think we were going to transition kind of to the next phase, which is really, you know, how do you decide who with hyperparathyroidism really should have surgery, and sort of how do you know which parathyroid is the problem? So Dr. Wilhlem, I know you were the lead author on the American Association of Endocrine Surgery's guidelines for the treatment of hyperparathyroidism. So why don't you start us off?
Absolutely. So first of all, just to make patients aware that, so in 2016, the American Association of Endocrine Surgeons drafted our first set of guidelines specifically for parathyroid surgery that were directed mostly for surgeons very specifically. And it really kind of tried to encompass a big part of this question is who needs surgery, and then things that help us guide in terms of that decision about which gland to remove, what surgery to perform. So they are very surgical-based guidelines. There are also other guidelines that have been written in the United States, the NIH consensus statement. There's a nice group of guidelines from the European group as well. So there's lots of resources out there. But the nice thing, at least for the AAES guidelines, they are freely available. You can search for them on Google under AAES parathyroid guidelines, and they will come up, and they are freely available if you ever want to look at them. So they're maybe a bit dry to read through. I wouldn't recommend like it's like some great bedtime story, but it's out there. But as far as starting to think about who needs surgery, so there are some very discrete things that that we would come up with. Once the diagnosis of hyperparathyroidism has been made, there are some patients that automatically we really ought to consider surgery. The first is just based on pure calcium levels alone. And that is taking the index level of the calcium from the laboratory where you had your blood drawn, and we look for a level of calcium 1 milligram per deciliter above the upper end of normal. The reason that that was chosen when the original NIH guidelines were written in the 90s, they chose a number of 12 milligrams. And then a few years later, they revised it to 11.5 milligrams, and it became a moving target. And the problem is every lab has a slightly different range. So Your upper limit at your lab might be 10.2, ours might be 10.5, in California might be 10.6. So it gives us a starting point. Secondly, patients with kidney stones. We're looking for concrete evidence of end organ damage from hyperparathyroidism. So once we start developing high enough calcium that it's spilling into the urine, the kidneys can no longer appropriately hold on to calcium and put it back into our system, and it starts to form kidney stones. That puts people at risk for obstructive kidney stones that can cause long-term kidney damage, urinary tract infections. We mentioned osteoporosis, which means significant bone loss compared to a set of normal patients of the same age. That puts people at an increased risk to develop fractures. And by fractures, we really mean breaking a bone in a situation where you might not normally expect it to happen. Then we can certainly talk about patients who've already had a fracture that we don't want them to develop further problems down the road. Geeta had mentioned looking at creatinine in patients. We know that as the kidney function starts to deteriorate, again, the body's ability to hold on to calcium also starts to go down. So creatinine levels that are elevated are another thing to think about. And then we talk about the age of the patient in terms of, especially this being, as Melissa mentioned, a disease primarily of middle-aged women. Right around the time of menopause, at about age 50, is where we start to see a big spike in hyperparathyroidism. But in women before that, if they start developing early hyperparathyroidism, that calcium loss chronically from their bones may put them at an increased risk to develop osteoporosis at a much earlier age than they ever would have, much more severe osteoporosis and higher rates of fractures. So those are, and then patients who might not be able to be appropriately followed long-term. So somebody who's going to be moving away, things like that, where this might be their best chance to get in and get an operation done as long as they meet all the other typical criteria. So those are some pretty standard things that would come along in guidelines, but it doesn't mean those are the only reasons we operate on patients. The symptoms that Melissa mentioned with not feeling well, mental fogginess, and energy complaints can be some of the most common complaints that I see in a lot of our patients. And they can be very dramatic and really impact your daily life and your ability to go to work, to care your kids, to do what you need to do every day. So just because you don't meet a specific outlined guideline that is in the AAES or the NIH or anywhere else, doesn't mean that you don't meet the criteria for surgery. In fact, that's the whole point, is that patients should be referred to people who are experts in this disease so that we can look at you, endocrinologists can look at you, someone who deals with this disease every day, to try to help you make the decision, are you the right person to get surgery?
So Geeta, with those guidelines that Scott mentioned, a lot of people have asked the question, will I be cured of my osteoporosis and will my kidney stones go away with surgery then? So if they meet these criteria, will surgery be curative of all of these symptoms?
That's obviously an important question, as you mentioned. Before I delve into that, I will echo what Scott mentioned, but also mention that, there really isn't sort of an age cutoff in terms of who can have parathyroid surgery, meaning sometimes if patients are older, often there's like this sense of, well, should we really refer them for surgery and things like that. And in fact, some of the symptoms that we've talked about are actually not typical of the usual patient, but are more common in older patients. So older patients will often have things like anorexia, weight loss, abdominal complaints and things like that. And as long as, they're otherwise fit and able to have surgery, there's no reason that they can't, see a surgeon and talk about their individual situation. With respect to what parathyroidectomy will do, absolutely, there's very good data to show parathyroidectomy will prevent the formation of new calcium-based kidney stones. Obviously, I tell patients that if they already have a bunch of stones, they may still pass them and still have episodes related to the kidney stones, but at least they shouldn't form new stones. If they do, then it begs a reevaluation of the type of stone it is, and perhaps there's another reason going on why they're developing kidney stones if their biochemistry is normal from a calcium standpoint. And similarly for osteoporosis, we actually know that with correction of hyperparathyroidism, you can actually stabilize bone density and in fact actually see a gain in bone density. The way I tell patients this is that, you know, imagine trying to treat osteoporosis. You have osteoporosis. Imagine trying to treat it when your blood calcium is high and people are worried about your calcium intake. It's trying to treat something like that with one hand tied behind your back, and it's not as effective. So, you know, that would be what I would sort of discuss with patients in regards to the outcomes.
All right, great. And Insoo, we have another question here. What is the success rate of surgery, and what are the main risks that you counsel patients about regarding parathyroidectomy?
Great question. If you were to talk to every surgeon individually in private, they would say their success rates are 100%. But we know that's not the case. It is a very high success rate, particularly in experienced hands. So that's a pretty important point to make, both with respect to success rates and the rate of complications that we'll get into in just a second. Generally speaking, when you're talking about going in for parathyroid surgery at a high volume center with experienced surgeons, the rate of success should approach 99%. With approximately 1% failure rate. Now, there are many nuances that I think that we can probably go into in terms of the different styles of surgery in order to get to the same result. And, you know, maybe that can be a tangent that we talk about in a second. Some people go after one parathyroid that they try to localize from an imaging study and rely on values of parathyroid hormone in the OR, the trends of drop, to be able to give you a sense of whether you've cured them. Other people do routine 4-gland or, you know, bilateral neck exploration. Either way, I think we can, depending on everyone's opinions, we can all agree that if you're used to doing what you're doing and you do it well, then your success rate should approach that 99% benchmark. The reason for failure is a few-fold. I think one can say that a surgeon is having a bad day. You know, so technical failure is a possibility. We all have to be humble and realize that we are, you know, not absolutely perfect all the time. But more importantly, you know, there are reasons for failure that have nothing to do with the quality of the operation, specifically regarding different weird locations where parathyroids can be located. You know, when you think about where the parathyroids are, you know, it sort of says in the name, it's typically usually by the thyroid, 2 glands on either side in various locations. And in about 1% of people, as far as we're aware, there can be embryologically, you know, weirdly located glands that we call ectopic glands. They can range from being more than 4, so that more than the typical 4 that we see, as well as the abnormal location. So some can be located in the mediastinum near the chest. Others can be located very high up in the neck near the skull base. Some can be in the carotid sheath, you know, in certain other locations. The good news is that if you're in experienced hands, the surgeon can look for most locations, not all, but most. And so you're left with the statistical odds that, you know, really good statistical odds, but still not 100%. The last thing is the complications. The 3 that we typically like to talk about are the risk of voice changes. So the most common reason for that are the recurrent laryngeal nerves being injured. Although, you know, just having surgery in and of itself can sometimes cause mild voice changes in a surprisingly high number of patients. The risk of recurrent nerve injury, which causes vocal cord paralysis and hoarseness, is estimated to be in most, I guess, big studies to be about 5% in that is the type that can you know, go away or resolve, and then 1% is a permanent rate. There's a risk for failure, as I talked about, but there's also a risk that if you dissect or touch all 4 of the parathyroids, that you ultimately either remove or injure too many parathyroids, and that can cause the opposite problem of low calcium state, hypoparathyroidism. Roughly about the same percentages as the recurrent nerve injury, about 5% temporary and 1% permanent. And then lastly, something that's a little bit more surgical focused is the risk of neck hematoma, which is a very acute problem that we want to make sure that you don't have after surgery. where your neck collects with blood, and that pressure can push on your airway and cause a difficulty in breathing. And that could be obviously an emergent situation. But thankfully, that risk is extremely uncommon, particularly for parathyroids, as opposed to another type of surgery that we do with thyroid surgery. So estimated to be about 1 in 300, 1 in 400 in some estimations. Those are the main things that we talk about. Obviously, there are some other complications, but we definitely need to touch on those as the highlights.
Sounds like there's a lot of different ways to do a parathyroidectomy, and not necessarily one that is far and above the best way. And it sounds like probably the experience of the surgeon is vital. And so how does a patient find an experienced parathyroid surgeon?
So Geeta, you ought to answer that one right there.
All right, well, here's a plug for the IT committee, but also, so I'll start off since we have Melissa online as well. So if you're already meeting with an endocrinologist, right, that's one source to find, someone who's experienced, because your endocrinologist should know several or at least one experienced endocrine or experienced parathyroid surgeon.
Absolutely.
Yeah, and short of that, if you're looking to self-refer or looking for other options, again, going to the AAES website, the patient portal side of things, there is a find a surgeon tool. You can search by area, by zip code, so it doesn't necessarily have to be in the same state. For example, we see in Iowa a fair number of patients from Western Illinois. We're closer than Chicago. So you can really, do by distance, by zip code, by location. So that's certainly another way, but obviously start with your endocrinologists and referring doctors too.
I think part of it is also having the courage as a patient, which I think sometimes is hard, but to ask the surgeon, what is your experience? How many of these do you do a year? And, surgeons will be honest with you, but you want to go to somebody who doesn't do this once in a while. You want to go to somebody that has a good experience and it's going to have the better outcomes for you. So what about, do all patients who undergo surgery for parathyroidectomy need general anesthesia? Like, what's the typical recovery? Is it outpatient surgery?
So, for my practice in general, I would say most of our patients do typically undergo general anesthetic for this operation. But we do offer the option of patients who have typically maybe some more severe medical problems, significant pulmonary problems, cardiac problems, that we can do these under some sedation with local anesthetic. We do what's known as a cervical block. So meaning that what we would do is once we come to the room, they'll give you the anesthesia team would give you some sedation. We actually use some numbing medicine behind the muscles on each side, as well as coming right where the incision is to help block the pain in some of the nerves in your neck. So we can go in and do the surgery without general anesthesia. But you're still awake. You still do, not enough that you would typically remember things, but you may be coughing or moving, and some of those small structures that Insoo had mentioned about the nerves. Certainly if you're moving and we're working around those things, it can be more challenging sometimes for the surgeon. So most of the time, I'd say, the majority of my patients I do under general anesthesia, but the good part is it's a relatively short operation. And as long as we're essentially removing single gland, which is typically the case for probably 85+% of the patients that I operate on, we're able to do your surgery. We watch you in recovery for a few hours afterwards to make sure you're doing okay, your breathing's good, your swallowing's good, your pain control's reasonable, you did not develop any bleeding or hematoma, as Insoo had mentioned, in your neck, and then you're able to go home the same day. So it's usually about a half-day surgical event, I would say, for the majority of my patients with single gland disease.
Great. There's a question
Yeah.
from the audience here about what is the best imaging study prior to a parathyroid surgery. And they also ask about what's the utility of doing an ultrasound-guided aspirate of a parathyroid. So I guess I would say is one, do all patients undergoing parathyroid surgery need imaging? If so, what type? And what if the imaging is just negative? Can you still do surgery?
I can start off with that. I think in this day and age, when we're talking about minimally invasive procedures, and as Scott mentioned, we know from when we did routine bilateral explorations that, meaning looking at both sides of the neck, most people will have one abnormal gland. And so in general, the common studies that are used to localize the parathyroid glands are something called a technetium sestamibi scan, or MIBI scan for short, an ultrasound, and sometimes other imaging like CT scans, specifically 4D CT scan, and as you mentioned, aspirating the parathyroid gland. They all have their advantages and disadvantages. I think the most commonly used ones, at least for me and maybe for others, sestamibi and an ultrasound. I think if you have those pointing to single gland disease, and then we can use an adjunct, meaning some level, checking parathyroid hormone levels when someone is asleep or during the surgery, that gets you to pretty good, very high success rates. If the imaging is completely negative, whatever imaging tests you decided to do and went in sequence, whatever you're comfortable with, it doesn't exclude surgery, because we talked about the fact that the diagnosis is biochemical. It may be that the glands are small and the tests are just not sensitive enough to pick them up. Even our best tests are about 80 to 85% sensitive, and this varies about who's doing it, which institution it was done in, what the specific protocol is. So, I think you still, that is not a defining criteria for surgery. Negative studies, you would still be a candidate for surgery based on the other things that we discussed, not just imaging. Regarding ultrasound-guided biopsies for parathyroid, I think, if you're with an experienced surgeon, they know what they're looking at in terms of imaging, and the location and everything will tell them that that's a parathyroid gland. I think there are some potential downsides to routinely biopsying things for that you think might be parathyroid. One, the glands are soft, the capsules are easily ruptured. You can get some bleeding, and that kind of makes the dissection a little bit difficult. And sometimes it can even raise the suspicion of cancer, because you get some scarring and it makes it look a little bit more worrisome at surgery. There's also always the danger of kind of seeding parathyroids, that can be a rare cause of recurrent disease. So in my practice, I reserve the biopsies for scenarios where I really need that information to confirm something is a parathyroid. As an example, if I had a patient who needed a reoperation, a second or third surgery, almost every test is negative except an ultrasound, and it sees a lump. I don't know if that lump is a lymph node or a parathyroid or something else, because I don't see it on any other study. In that situation, before doing redo surgery, I may get a biopsy, maybe even check it for parathyroid hormone levels, because the risks that I mentioned are kind of outweighed by the benefit, because then I know I'm going for a parathyroid. I can tell the patient how I'm going to approach it, what the success rate will be, etc. So that would be my approach to it.
I would very much agree with what Geeta said there, and just to kind of go back to the very first part of what she talked about, and I think to that patient question a little bit too, was just because you have negative imaging does not mean that you do not have hyperparathyroidism, that you could not benefit from surgery. I think it's a common mistake that we will sometimes see for patients who then, as you mentioned earlier, I think, Chris, that they become very frustrated because they kind of float around with these numbers and they keep getting told, well, my calciums are high, my parathyroids are high, but no one can see them. You still have hyperparathyroidism, and you could certainly still benefit from surgery. And the main thing is that exactly what Geeta just said, is that the imaging is not any part of your diagnosis. You are diagnosed based on your blood tests and your symptomatology. And then from there, the process is deciding operation. But if you have negative imaging, it's a much more likely scenario that your surgeon's probably going to need to look at all 4 of your parathyroid glands, because you're probably going to be at a higher risk to have what we term multi-gland disease or hyperplasia, where all 4 of your glands are just a little bit larger than normal, but not enough that they show up on an ultrasound well, not enough that they show up well on the parathyroid sensitivity scan well, but you still have disease and you could still benefit from surgery.
So just the final answer to the question from the audience, I think, is that there isn't necessarily one best imaging study. Some institutions preferentially use sestamibi. Some might use what's called a 4D CT scan. Some just do surgeon-performed ultrasounds. If it's clearly something abnormal there, then they wouldn't get these other imaging modalities. But sometimes for especially preoperative patients who have had persistent or recurrence, it's important to get those imaging modalities and multiple imaging modalities to be sure, because that's much more challenging surgery. And then one big difference, well, maybe not a big difference, but a difference between the AAES guidelines and the NIH consensus statements was that, Scott, you guys included kind of neurocognitive, sort of more subjective symptoms as an objective criteria to say surgery is warranted. So when you see a patient who has, maybe doesn't meet any other clear-cut, strong indication warranting surgery or mandating surgery, if you will, and they have a lot of these subjective complaints, what do you tell them is the likelihood that those complaints will improve following the surgery?
Sure, I think that's a great question. And part of it, I think that patients always need to realize is that when we're talking about individualized subjective complaints, fatigue, depression, foggy memory, difficulty concentrating, those things are multifactorial. Your hyperparathyroidism is probably a part of it, but your diet, your other medical problems, your sleep habits, your stress at your job, living in the COVID era, all of these things can make us all feel kind of depressed and kind of miserable. So I think it is important that I try to counsel patients that our hope certainly is that we know you definitely have a biochemical problem. You have an abnormality with your parathyroid glands. Your surgery is certainly going to be directed to correct those biochemical abnormalities, and we certainly hope that some of those subjective things will improve. I would say in general, the majority of my patients do come back and tell us that they feel better after surgery, but not everybody. And the time frame is also different. I have some patients who wake up the next day and they feel great, and I have other patients that may take them a month or two. And then, as we said, some patients, maybe they get parts of it back where their energy's a little better, but maybe they still have some depression. And maybe that didn't have anything to do with their hyperparathyroidism to begin with. But I think to the point of the difference in the guidelines that the AAES wrote compared to the NIH guidelines is that, number one, there's been some more time that's gone by, and there's been some really good studies that have come out using standard testing, SF-36 scores, things that we look at to try to figure out how patients are going to do from some of these emotional components related to their disease process. And we've got good data that does show that those things clearly can get better with surgery, which is why we chose to include that as a recommendation for surgery in the AAES guidelines, because there's newer data, and that's the beauty of it. As things evolve, we learn more about disease processes, and we can counsel patients better.
So Melissa, I have a question for you that's related to one of the audience questions. So what happens if after the surgery, the patient still has an elevated calcium level? Why does that happen sometimes? And how do you follow patients after a parathyroid surgery in terms of kind of persistent or recurrent disease?
That's an excellent question. And thankfully, we don't encounter it too much because of the excellent endocrine surgeons out there. But when it happens uncommonly, we approach it the way we approached it in the first place. When the calcium is high, step one is going to be figuring out, is this PTH driven hypercalcemia? Is this related to the parathyroid gland, or is this pretty much not related to the parathyroid gland? If it's not related, then we'll go down a whole different avenue looking at the various other potential causes. If it's related to the parathyroid because the PTH is either high or it's inappropriately normal, we definitely will revisit to make sure that the correct diagnosis was made, meaning that it's definitely not that uncommon genetic condition, that familial uric hypercalcemia. And also, sometimes we even consider, could it be something also uncommon, like one of those multiple endocrine neoplasia syndromes, in which case people will have a higher risk of all 4 parathyroid glands being involved, in which case we might have to think about potentially doing more. But we definitely, step 1 would be starting with revisiting and confirming the diagnosis.
All right, another
One
common
thing,
question. Go ahead, Insoo.
Sorry, one thing that maybe we could emphasize to patients is that it's very important not to look at an isolated PTH, a PTH in isolation without the concurrent calcium level, because ultimately, those relationships are seesawing all the time in your body. So, very often, not very often, thankfully, our endocrinologist will not allow that. But sometimes I will see patients who are coming and they're convinced that they have hyperparathyroidism and they have one value that was slightly above the upper limit of normal with no associated calcium level. So it's just very important from the patient standpoint, advice that we can give is to make sure that when you're getting either surveillance labs or getting worked up for the first time, that you're getting all of those values all performed at the same time.
All right, great. So we're obviously a very surgically oriented group here, but another common question that we get here is, does everyone with hyperparathyroidism need to have surgery? Can it be monitored, or can you just take a medicine like Fosamax if your only symptom is osteoporosis? So I'll open that up to the group.
That's a really good question, and that's also something that I commonly see on the endocrine side. And the short answer is that no, not everyone will need surgery. As before we started talking about some guidelines, there are some patients out there who are truly, truly asymptomatic. The calcium is very mild, and in those cases, we follow the patients with routine lab work, looking at the calcium, the parathyroid hormone levels, bone density, the urine, the renal ultrasounds to assess for kidney stones. And then I think the second part of the question, Benzon, that you mentioned was, what if they have osteoporosis? Can they just be treated with something like Fosamax? And in general, when people have the primary hyperpara and it's affecting their bones, we will be recommending consideration of surgery. Some patients, for various reasons, might not want surgery, or they're medically unable to undergo surgery, in which case, yes, we can offer a medication to treat it, certainly like Fosamax, like the bisphosphonates. Those are the class of medications with the most data in terms of using an osteoporosis medication in the setting of primary hyperparathyroidism, and it has been shown to be effective as well. That being said, we have also seen patients in whom they have primary hyperpara and we're using bisphosphonates, and yet they continue to have bone loss. And in that case, it would be important to treat that underlying cause of the osteoporosis with consideration of something like a parathyroidectomy. In other cases, patients might not have osteoporosis. They may simply have a very high calcium level that's causing symptoms. And for some reason, maybe medically they're not able to undergo surgery. And then we have a different medication called cinacalcet that can lower the calcium levels and can lower the parathyroid hormone, and that can be used to help treat the symptoms of high calcium. And in people who might have both, like a very high calcium causing symptoms plus osteoporosis, we can use both together as well if they're not able to undergo surgery.
Okay. So let's answer some of the questions from our live audience. One question is it possible to differentiate from lithium-induced hyperparathyroidism and primary hyperparathyroidism? And are they really different?
I'm happy to take that one. Biochemically, they're going to look pretty much the same, and it's coming from oftentimes it's coming from the parathyroid hyperplasia. And oftentimes the people who are taking lithium, they need the lithium. It's very helpful for its primary purpose. So we would consider that in light of what to do next, meaning we wouldn't necessarily be stopping the lithium in order to repeat labs. In contrast, if we see that someone is on a thiazide medication, that blood pressure pill like hydrochlorothiazide or chlorthalidone, a common thing to do would be to stop that medication, and repeat the whole panel of blood work 3 months later. The majority of people will have underlying primary hyperpara, but a portion of people, the labs will completely normalize.
And I would just kind of caution patients, if you're told that, that you're on lithium and someone tells you, oh, well, you should stop your lithium because that's causing your high calcium, again, make sure you go back to your primary care doctor or your prescriber who's giving you those medications. I've had patients come to me and they stopped their lithium because they were convinced that that was the whole problem, and they wind up with a whole other host of problems. So just remember, when people are talking about things, or we're talking about this as a panel, we're talking about general scenarios. We're not looking at you as an individual. So you need to talk about these things in concert with your treating physician and make sure that you're doing what's appropriate. Many times they may be able to find other options for you, but don't do it out as a solo individual or, by listening to us for an hour.
And then we have another question, and I think we can look at this both in general and specifically for this patient, but this patient is diagnosed with a giant parathyroid adenoma. What questions should I be asking my surgeon in my upcoming first appointment? So I think that's a great question just for anyone with hyperparathyroidism, as well as specifically for a patient with a large adenoma. What are the biggest concerns that I should ask about?
Well, one of the bigger ones, obviously, a bigger adenoma is, generally speaking, correlated with more severe biochemical dysfunction. So you definitely want to make sure that they are medically controlled as much as possible. You don't want them to walk around with a calcium level of 13 or 14. If that happens to be the case, you want to make sure that they're reasonably well hydrated and being treated. The other major thing is the bigger the tumor, the thought needs to come into your head about whether or not this could be those rare parathyroid cancers. So a lot of these things can be, you can have some measure of preoperative suspicion based on the level of PTH that's in the blood, as well as the calcium levels. Typically, they will be much higher than a standard case of primary hyperparathyroidism. And then some things that we have been classically taught to look for. If the mass itself is palpable, then you want to be a little bit more, afraid or concerned that this could be a cancer and be dealt with appropriately. And then lastly, when you're in the OR, classic parathyroid cancers can have a look to them, a little bit more of a grayish appearance, could be a little bit firmer, could be more sticky to other things. So those things are certainly, game time decisions and findings that the surgeon needs to be very careful about.
Other things on pathology that can help the diagnosis of parathyroid cancer, which is I think what the audience member is concerned about, can be a very difficult diagnosis. And so, if there's direct invasion into other structures, but pathologically things, if there's a lot of fibrosis within the gland, nuclear atypia, or the other thing, there's what's called parafibromin. So if there's lack of parafibromin staining on the immunohistochemistry on the pathology, then that is something that would definitely be concerning for a parathyroid carcinoma. Again, that's very, very rare, but that is something that potentially you could ask to see if they, did parafibromin staining of the tumor sample.
And I think maybe one other thing too, just that the patients need to kind of be aware of when you're talking about a large parathyroid, when we're thinking about the possibility of parathyroid cancer, which Melissa mentioned earlier, is a less than 1% of all patients with primary hyperparathyroidism will have parathyroid cancer. But your surgeon may also talk to you and tell you that when they go in to do your surgery, that in order to successfully remove a parathyroid cancer, for which really the only good treatment we have is surgical removal, is that it may necessitate removal of other structures near your parathyroid gland. And that could include part of your thyroid gland, under rare circumstances, the laryngeal nerve. Typically, we might have evidence of that before the surgery. You might have hoarseness of your voice. You might have changes that would make us suspicious. Your surgeon may recommend that they take a look at your vocal cords before surgery with what we call laryngoscopy, where they put a small flexible camera down in the back of your throat to take a look. So there may be some other things that your surgeon may talk to you about that may be involved in the process of your surgery when you get to something that's outside of the normal expected findings.
So all the things that have been discussed so far, kind of, just to kind of follow up on one of the other audience questions as well is, as we're saying, the diagnosis can be suspected preoperatively based on really high calciums or really big glands, or it can be suspected at the time of surgery when, as you heard us say, there's evidence of scarring and the parathyroid is pushing into or invading into the thyroid or other surrounding structures, or you have hoarseness. Obviously we rely on the ultimate biopsy, which is the pathologist, to tell us, if it's under the microscope looking like a parathyroid cancer, it's going into arteries and veins. But sometimes that diagnosis is tough. And one of the rare reasons that someone might get recurrent hyperparathyroidism or having the high calcium come back is because it was actually an unsuspected cancer. So the best treatment for that is surgery, but I think one of the other audience members had asked earlier, if you've had surgeries for parathyroid cancer and either it's spread or elsewhere and it's no longer surgically resectable, then you're looking at sort of medical treatment of the high calcium, similar to what Melissa mentioned earlier, using something like cinacalcet to reduce the parathyroid hormone levels and calcium levels. If the risk of surgery is too high, or if it's not actually able to be resected without compromising function and things like that. Does that sound I think we're just following up on what we were discussing.
Absolutely. And I think too, and I think a point of that for patients, if you have experienced something like that where you had a parathyroid resected and either you had a failed surgery or you had a cancer and you had a recurrence, you now have kind of moved beyond what surgeons who do some parathyroid surgery, but as Insoo had mentioned earlier, not a high volume parathyroid surgeon. You might want to then start to seek out second opinions or look for a local expert in your area. Again, that can be done through the surgeon finder on AAES. Talk to your endocrinologist, look for other second opinions. But when you're talking about reoperative surgeries and parathyroid cancer with recurrences, you've stepped into a little bit of a different realm, and you might need to have a little bit more of an expert opinion beyond just someone who does a few parathyroids per year, which some surgeons do a very nice job with.
And even though we prepare for the worst in these patients, the most likely diagnosis in this particular patient is still going to be a benign parathyroid adenoma. So that certainly is important to remember. I think we have time for one last quick question maybe. And how common is persistent elevated PTH after parathyroidectomy for primary hyperparathyroidism, even with normal calcium? And what does that mean if the PTH is elevated, but your calcium is normalized, let's say in the first 6 months after surgery?
So there's been a couple of really nice studies that have been over the years. And if you look at everyone who has parathyroid surgery, and if you go back and measure their parathyroid hormone levels routinely afterwards, up to 15 to 30% of patients out there can actually still have elevated parathyroid hormone with normal calcium levels. In most circumstances, you are probably cured. Your problem is probably due to one of those other secondary causes we talked about earlier. So the first thing I usually do is, number one, we would repeat the calcium and the parathyroid hormone again. We get a vitamin D level. If your vitamin D levels are low, oftentimes if we replete those, what we like to see is as the vitamin D goes up, the parathyroid goes down. We feel much more comfortable with secondary disease. Other things, if you had really bad osteoporosis before surgery, we can see bone turnover that can contribute to persistently high PTH. But we as surgeons always have to keep in mind that maybe you are a failure as well. And so you do need ongoing monitoring to keep an eye on, as Insoo had mentioned, your calcium and your PTH together. Very important to look at both together. But the majority of patients out there who have a mildly elevated PTH after surgery with normal calcium, you probably are cured, and it's probably due to a secondary source.
Agreed.
Well said.
Okay, well, I think we're at the end of our hour. I learned a lot. Hopefully our audience members did too. And again, it was really a privilege to help moderate with Benzon, all of you experts.
Great. On behalf of the IT committee, again, I want to extend our thanks to our panelists, our moderators, and our AMR staff, Lauren and Ashley, without whom we can't do these events. And also a big thank you to Parathyroid Disease and Support and Awareness Group, really an important resource for the patients. And you know, we look forward to continuing to partner with you to help increase awareness about primary hyperparathyroidism and other parathyroid conditions, but also you know, treatment options and just help improve the care of our patients overall. So thank you very much for joining us this evening. And as I mentioned earlier, if you missed this event, it will be available on the AES YouTube channel. And we will post an announcement and a link in that regard. So thank you very much to my co-panelists and committee again. Have a good night.
Thanks for having us.
Thank you. Good night.
Thank you.
Thank you.